This week on the Post Call podcast, we are going to talk about what makes a good doctor-patient relationship, or I guess what patients care about in their doctor-patient relationship. We're going to talk about when you can and can't maybe accidentally have a beer before work. And, of course, the conversation part of this episode is going to be from someone who's been on the show before. Dr. Ilana Yurkiewicz, a Hem-Onc fellow at Stanford, led a conversation about difficult conversations that Hem-Onc fellows and residents need to have with their patients, things like how to answer the question, how long do I have left? What therapy, what kind of curative therapy can we try? When's it time to end curative therapy? Things like that. Really good stuff from Dr. Yurkiewicz and two residents that work on our sister podcast, Blood and Cancer. And I'm joined this week, as I always am, by Dr. Emi Okamoto, who is traveling yet again this week. She is in Rwanda, and I hear it looks like the Shire from Lord of the Rings.
Yeah, it's so pretty. Hills, green, even in the middle of the city. And they had a ban on plastic bags, so there are no plastic bags.
Oh, well, I'm recording this in California, and they also don't love plastic bags here. Target charges you to get a plastic bag. Welcome to episode 51 of the Post Call podcast. I am the voice of MDedge podcast, Nick Andrews, and like we said, big show this week. Going to kick it over to Dr. Ilana Yurkiewicz for a conversation about tough conversations that you have with patients in medical training. But, Emi, I wanted to start with this interesting article that we found, what patients care about in their doctor-patient relationship.
Yeah, and it's funny because you think about what doctors care about, and it's like the relationship, the human side, connecting with the patients, and the patients are like, I want convenience, someone close to my house.
Yeah, make it easy. Let's see. This is a 2018 study by VCU, the VCU Health System. 61% of patients would switch doctors for the ability to get an appointment quickly. 52% would switch to get an appointment at a convenient location, and 51% would make the switch for great customer service.
Yeah, and it makes you think about, what has the healthcare industry become? It really, patients care about a service industry sometimes more than that relationship that we really value and strive to build with our patients, which we still should, but.
Right, and that's a conversation that's increasingly being had in healthcare, right? Like maybe AI can diagnose me. Well, actually, my internist can tell that I'm feeling weird and then ask the right questions, and it's a delicate balance, but it's certainly different than Uber Eats or Yelp reviews, I would like to think anyway. So this is an article published by Medscape, and they're owned by the same parent company that owns MDedge. You can take their questionnaire that asks questions about what matters to you about the doctor-patient relationship, such as what do you think makes it for a good relationship, loyalty, patient clarity, visits are warm and friendly, et cetera, et cetera. So you can find a link to that in the podcast notes. I wanted to move on to our second topic here, Emi. I thought this was really interesting because it's kind of a catch-22, and it can get clinicians into hot water, and it's like a really weird area for people who take call. So we're going to read the original post on Reddit. It's called Having a Beer Before a Shift. I was at a bar yesterday and got called to come in and help at the urgent care. I agreed to it without even realizing that I was actually halfway through my second beer. I was by no means drunk, but still didn't feel entirely comfortable about going into work, but I committed. And this person asks, have you been in similar situations, and what did you do? So what did you think about this question?
Yeah, it's a great question, and it generated a lot of discussion, particularly because a lot of people, especially in, smaller practices, are on call almost all the time. And it might not even be going into the hospital. On one end, you could be called in to do surgery, or on the other end, you could just be taking a phone call, from patients saying, oh, I have chest pain. What do I do? And so anywhere on that spectrum, we're expected to be on and to be doctors. But I think the thing running through this thread is if there's, and it's mostly for litigious reasons, if there's anything that might come back and bite you, just don't do it.
Right. Which is really interesting to me because perhaps, I don't know what the conversation should be like, and I don't know what the data show. I am reading, there's someone who says or claims to be that they are a medical malpractice insurance manager and an emergency physician doctor. And they say that the risk to the patient and to you is so low if you are in this situation, but legally you might be at a little bit of risk, but it could be worse for patient care and for the clinic if you don't go. It's a really interesting catch-22 where technically you probably shouldn't, but in some circumstances, if you are like this original poster, like one beer in and you are in rural and taking urgent care call, maybe you should, or maybe you should say, I can come in an hour. I don't know.
Yeah. And a lot of people said, at the end of a 24-hour shift, I am certainly more incapacitated than after I've had one beer. But, what is the scope of my job versus something I choose to do that could impair me? So.
Right. And that's tough. And like, that's something I'm getting here too, where people should, say like, well, if you're one of these, what if you're a rural physician where you're technically kind of on call literally every second, always? Are you just not supposed to live your life?
Yeah, and that's what someone wrote in there. Like, a rural physician told me I just don't have beers anymore. But yeah, so I don't think that every rural physician should do that. But yeah, it brings up a great question.
I don't know how I would handle it, but I do. This is one of the reasons I like medical Reddit, and you can find a link to this thread in the show notes. And I highly encourage people to get on there and check it out, because the anonymity factor, you have to take everything with a grain of salt, because I'm not a physician, but I could claim to be on Reddit if I tried hard enough. So you have to take everything with a grain of salt, unlike Twitter, where you can kind of verify personality a lot more. I think the conversations that are happening on Reddit are really genuine, like this one, where people can kind of truthfully say, like, I accidentally had 18 ounces of alcohol slowly before I went into work, and I think it's really important to participate. And I like to think that post call is adding to that as well.
And you can drive after you have a beer. So yeah.
Yeah, exactly. Like I could, right? We've had drinks doing the lounge before, haven't we? Yeah. I mean, if you were in an emergency situation in Dillon, Idaho, and you needed to go in after 1.5 beers, I mean, I think you would want to go in, but that's a tough conversation, and one that I don't think we're going to exactly ever get figured out, but one you can participate in by navigating to the show notes. Okay, I wanted to switch gears again to a ever-present topic at post-call, which is burnout. This is a roundtable discussion published by MDedge OBG Management, that's OB-GYN Management, and it is titled The Electronic Medical Records Role in OB-GYN Burnout and Patient Care. And this is an edited, reviewed, published roundtable. And Emi, what did you think about how these high-level clinical OB-GYNs discussed how the electronic medical record is impacting their practices?
Yeah, first I've never seen a roundtable written out like this, so it was very nice to have everyone just contribute at once.
Yeah, not bad, right?
Yeah, everyone did agree, like absolutely agree, 100%. Number one problem, EMRs are what's driving a lot of the burnout in their OBGYN. And just we're able to illustrate that with examples coming from their own institutions. And so it shows that these very high level people are acutely aware of the problem as well.
Yeah, and they're all saying this on the record. This is Dr. Mark Woodland, who, of course, Emi just said, EMR computerization is the number one issue relating to the dissatisfaction of OB-GYN providers at my institution, at our institution, is what he said. And he talked about having multiple systems and different systems. So I think this is something that's been alluded to for a long time, and it's like rub some dirt on it, which is my version of saying like do yoga or meditate or other things that have been said. But we talked to Dr. Eileen Barrett months and months ago, right before Emi joined the program, and she said, well, the issue is the EMR, so we can't sugarcoat it any longer.
Yeah. Yeah, so I'm interested, they have the roundtable, you have this discussion, and then you need to get the commitment from these people to make the next steps. It's one thing to show awareness in the high level, but then you need to, catch them right there and then and say, okay, so how are you committed to making a change in this?
Exactly. I mean, what else are you gonna? It's just it's so astounding, and I guess frustrating to me. Where like I'm in California visiting some friends, and one of them has a Tesla, and I can touch a button on my phone, and the car drives to the restaurant and picks us up. Like from the parking lot to the restaurant, it drove and picked us up with nobody in it. But yes, dude, it can You can download this app and touch the thing, and like it self like valets itself. But the EMR is driving burnout. What the hell? And this is like, I mean, I can't say it any other way than how can this car drive itself, but we can't figure out how to have everything working correctly, even if it's a for-profit business and the legislative, ethical parts of it haven't been figured out. Even with that aside, how can I touch a button on my car, shows up at my house with no one in it, and we can't figure out what's going on with EMRs? Not to be critical of any company specifically, but it does seem backwards to me.
Yeah. Although, to be critical of one company, they did bring up in the roundtable that one of the high-level administrators hears the word epic fail at least once a day.
Yeah, I mean, they named that company that. They kind of did that to themselves, Emmy. I'm not gonna lie to you. I mean, that's what it was always going to be, I suppose. So you can read that roundtable in its entirety. If you are interested in OB-GYN, or if you are a practicing OB-GYN or nurse, you can look at everything that we have for OBG management, which is journals and articles and everything at MDedge.com. The link to both of those things will be in the show notes. So I wanted to talk about and introduce our final segment, which is a conversation led by Dr. Ilana Yurkiewicz. Those listeners who have been with us for a while can remember she was a guest on the show earlier this summer. She is a clinical hematology oncology fellow. She produces a segment for our Heme Onc podcast, Blood and Cancer, which is called Clinical Correlation. So she's a columnist, and she does clinical correlation for blood and cancer. All of her work is based around the kind of cool observations and difficult conversations, the human side of hematology oncology care, as she calls it. She does things like, when a cancer patient asks about diet, what can you tell them about diet, how to have difficult conversations with them, what if the family doesn't want to do care. And so she led a conversation with two trainees who work on the notes part of Blood and Cancer, who write the show notes, which, as Emmy has done for a very popular podcast called The Curbsiders, all of you have heard of it. It's really hard to do those show notes, isn't it, Emmy?
Oh, yeah. Yeah. And people should read them. I'm just going to throw that out there.
Well, I can tell you this. If it makes you feel better, people asked for them. They want them real bad. So that's good. So the people who do the notes for Blood and Cancer, they are residents, and they joined Dr. Ilana Yurkiewicz. That's Dr. Ronak Mistry and Dr. Emily Bryer, and they joined Dr. Yurkiewicz for this conversation. And it's about really tough things that HEMONC trainees go through, but all physicians and clinicians have to go through in some aspect, which is questions like, how long do I have left, and like when to switch to palliative care, and what to talk to family members about. And that's really tough stuff that I imagine you do role play and you want to think about it. But in training, when you get punched in the face with that, it's got to be really tough.
Yeah, and I think it's important for everyone to think about. It really, I was reading When Breath Becomes Air finally, and he was bringing up kind of when he has those conversations and just really highlights how hard it is to actually have them when you're in the moment and in the scenario. So I'm very interested to hear her thoughts.
Yeah, it is. It's really difficult, and it's something that you got to go through. And I hope that those of you who are through training and attendings who are listening to this can kind of, rewind a little bit, because it's one of those things. And I mentioned this with Dr. Henry, the host of Blood and Cancer. It's one of those things where it kind of somehow is both, it becomes routine or you become practiced at it, but it never becomes ununique. It's always different and always hard every time. So if you just need a little refresher or want to have this conversation again, I invite you to stay tuned for Dr. Ilana Yurkiewicz, Dr. Emily Bryer, and Dr. Ronak Mistry. But Emmy, I think that's going to do it for us. I kind of want to monitor how this Reddit feed goes and see what people have to say about drinking before going to work accidentally.
Yeah. Don't do it, or try not to.
Or try not to. So you're in Rwanda. Where are you headed to next? You're going back to Cambodia? Oh, well, I bet. I actually am away from my cat for a week here in California, and I kind of hate it. I want to call people like, hey, can you just go check on my cat, please? Yeah, no, she's good. There's food and water hidden all over the place. It'll be like a scavenger hunt. Bella is still the queen, and I know who I serve. Let's be real.
So I'd like to move on to the third case. And the theme of this one is the patient and family ask, what would you do if this was your family member? So the case is, you are the fellow meeting a new clinic patient presenting for a second opinion. 2 years ago, she was diagnosed with a renal cell carcinoma and underwent a nephrectomy, but unfortunately the cancer came back soon after and was found to be metastatic. The patient was started on chemotherapy and then immunotherapy, but it progressed, and most recently her course was complicated by fevers and an intra-abdominal abscess that could not be drained. She continues to have fevers even with antibiotics. She discussed more chemotherapy with her local oncologist, who noted that if the abscess is the cause of her fevers, additional chemo would worsen her immune system and could worsen the infection and lead to death within weeks or sooner. At the same time, this is the only chance they have to fight the cancer. She tells you she cannot decide what to do, and she asks you, what would you do if this were your family member? Have you ever experienced a question like this?
I don't know that I actually have ever experienced a question just like that. Ronak, have you?
Not in this particular context. I've received this question oftentimes. I've seen it most in the ICU when we have critically ill patients, many of whom have a very tenuous status. And this conversation comes up when we're having goals of care discussions about, whether the patient would want life support, whether they would want resuscitation, then mechanical ventilation, etc. Actually, not too long ago, I unfortunately had a very young patient that had a poor outcome and came into the hospital with hypoxic and rather anoxic brain injury. And his family had his mom said this exact thing to me. If he were your family member, what would you want us to do? It is incredibly difficult. I think in that particular situation, what I learned is the most important thing that I found for this family was for me to be very straightforward and say, how honest do you want me to be? And that worked incredibly. And, unfortunately the patient had a poor outcome in the end, but I can't even tell you how grateful this family was that I said that one little thing, because they told me they would want me to be as honest as possible. And not that I would ever withhold information, but I think it changes the way that you deliver the information. They wanted me to be very straightforward, and they were just so appreciative in the very end. And I think that is, the best lesson that I could ever take away from the experience that I had.
What did you tell them?
In this case, I told them that I expected this to be a very poor outcome. I didn't expect the patient to live without the aid of pressors and mechanical ventilation. And they took it, very hard, and they were very upset about that. But after I gave them some space and I let them think about it and I checked in on them, they realized after seeing everything that we were doing, that, I wasn't giving up on their son. I wasn't telling them that I was going to do all that I could to try to reverse this. But they understood where I was coming from. And again, it kind of just gave them, in the best case scenario, they were hoping for something to turn around, but they were mentally preparing themselves for the worst case scenario. And I think that was really, really important to this family.
Yeah, I think that's a really powerful approach that you took. How honest do you want me to be? I really love that approach, because I think, the first thing you were doing, like we were discussing in one of the previous cases, was really you were addressing the emotion behind the question. Something palliative care teaches too is look for the question behind the question. What are they really asking? And I think by someone asking you, what would you do if this was your family member? It's really a trust question. And they're asking, can I trust you to take me seriously as someone you care about, as someone you would care about and make decisions for, as well as your own family member? And by answering how honest do you want me to be, I think you're first addressing that, you're validating that, you're acknowledging that you're on their side, you're not going to abandon them, and you're establishing trust. You're establishing that you take them seriously and will give them the best possible information that's in your power. So I think that's a really fantastic approach. And, getting into then, we talk about the emotion, validating the emotion, and then the actual content. I mean, what if they say, I want you to be as honest as possible. If this was your mom, would you pull the plug or not? That makes it, a very, very difficult conversation. And how would you answer something like that?
I, of course, would have a hard time answering that. I know for sure, especially because when you now insert this being your own family member, you add that whole emotional component in your own mind. That being said, I think that this really does all cycle back to this whole theme of, I think, everything that we've been talking about tonight is really trying to understand what is the ultimate goal here. And I know that for my family and for my mom, the goal would always be quality of life. And so, if that's the case for this family, then, I might say, I don't know if I would ever use the term pull the plug for sure. But I would probably say that, maybe we should realign what our focus is here and try to find ways to ensure that she enjoys the time that she has, rather than, because in that case, it doesn't sound like you're withdrawing care or withholding care. Instead, you are opening up the discussion to other options that may not be medications per se, but other things that help improve the family and the patient's quality of life.
Yes, I completely agree. What you're getting at is the theme that we've been talking about, which is understanding the values of the person. And it's hard to answer that question if you don't know the values of the person, because the values of your mom or dad can be completely different from the values of this person or this person's family member. And so first I think another theme that I'm bringing up here is often just being really explicit, and breaking the fourth wall and saying that. And I've said things like, well, I know my family members and I know what their values are because we've discussed this before. And I don't know what your values are. Can you tell me what's important to you? So being explicit about the differences and what you're trying to tease out from the person. And Emily, I think it's really interesting that I guess I find this, I was bringing up really common scenarios that I get in fellowship. And I think it's interesting that you haven't gotten this explicitly just yet. Perhaps it's something that comes up actually more in the outpatient setting, and in residency, you guys probably have more experience in the inpatient setting. But this is this comes up a lot when someone's coming to you seeking a second opinion. They want to go to Stanford or University of Pennsylvania because they're these big name hospitals, and they think you have all the answers, and they're there to get a second opinion, and they want to know if they can trust you to give them as good care as you would give your own family member. So I've actually gotten this question many, many times, and I imagine you guys will as well, more in the clinic setting. So I'd like to move on to one more case. And this one also revolves around family dynamics. And this is the theme of this situation is where the family asks you not to tell the patient that they have cancer. So the case is you have a new patient in clinic who was recently discharged from the hospital for a GI bleed and was unfortunately found to have metastatic stomach cancer. He is recovering well from his endoscopy and biopsy, and he is here today with his wife and 2 children to discuss the results and next steps. Outside the room, his daughter comes up to you and says that the inpatient hospital has told them it was metastatic cancer. She asks you to please not tell her dad, as it would destroy his morale. Is this a situation that you guys have experienced before in residency?
I have not experienced it with a cancer diagnosis, but I have with kind of HIV diagnoses and other diagnoses. But I think, the responsibility of the treating physician is to the patient and they should, involve the family as much as they can. But I think it's the responsibility of the physician to speak with the patient about their health.
I agree. I think that at the end of the day, like Emily said, I need to inform the patient. I need to let him or her know what the situation is here. But again, just using this as an opportunity to speak with this family member and kind of dive a little deeper into what their apprehensions are about this diagnosis is really, really important. And then at the end of this discussion, explain to them that, while you understand where they're coming from, and again, it's coming out of a good place, you are treating the patient, and it's important to him or her. It's important to you to tell him or her about this new diagnosis.
Right, that's exactly right. So, I think you're both hitting on the point that the patient's autonomy comes first, and your obligation as the cancer physician is to the patients primarily. Of course, it's to the family as well, but it's up to the patient to make that decision. And so what you have to do in these situations, what you have to navigate is telling the family members that you will have to ask the patient directly what their preferences are. And sometimes the patient will say, that's fine, just defer everything to my kids. I don't need to know the details, and that's fine by me. And other times it might surprise the family when the patient says, no, tell me absolutely everything. I actually want to know all the details. And if the second situation is the case, it is your obligation to then explain to the family and to the patient that you have to do what the patient wishes, which is to tell him or her everything that they want to know. And I think the second point that you guys are hitting on as well is, it's while your obligation is to the patient, it's important to recognize what the family dynamics are and try to tease those apart a bit, and to commend the family, because their instincts are they're trying to protect the patient. They're looking out for what they think is their best interest. And this is another situation where I might explicitly say that I applaud you for looking out for their best interest and not trying to take away hope in a really difficult situation, but that it is ultimately his decision. Any thoughts on how you might phrase that? And what I mean is, how would you phrase that to the patient in front of the family, that you're trying to understand what the patient wants without offending the family, without rejecting what their wishes are.
And I've seen this conversation being had. I should mention that our palliative care team at the hospital is pretty great, and I've had the opportunity to sit in with them in a lot of family meetings. Again, not necessarily about cancer diagnoses, but any sort of terminal diagnosis. And one of the things that they've done really well, which I've tried to emulate in my own practice, is trying to figure out where the patient's at, and explain to them, in this case, I understand that you were recently in the hospital, and we did some tests. What do you know so far? And kind of see what their understanding is. Something else that they often do in these situations is also then go on and say, what are your concerns and what are your fears, in regards to whatever just happened. And I think that again lends itself to indirectly figuring out where the patient's at emotionally, mentally, and goal-wise. And then you kind of, I think thereafter, I think you have to kind of lose the generic approach and kind of feel out the room. And that's where the conversation will be very much dictated by the emotions that you can feel from the family members, from the patient. And like Emily said, that's your opportunity to kind of figure out, how much the patient wants to know.
Yes, I think that's exactly right. I mean, it's incredibly important first, before you start bombarding people with information, is to find out what they know. And I can tell you, I've been in many situations now where I've been surprised by what what they answer, where you think someone has a really nuanced understanding of their disease, and then they'll say something like, oh, I have a tumor in my liver, and then it's not in their liver at all. It's actually completely a different type of cancer somewhere else, or that they don't even know they have cancer. They just say, oh, I'm here because I heard I was sick with something. And before you start giving information, taking a step backwards is figuring out where the patient is and where the family is, so you can meet them there and then go forward. And I think the other thing you said, which I think is also fantastic, is sitting in on or inviting palliative care to these conversations that you're going to have in fellowship, and always remembering that they are just such a fantastic resource for difficult conversations, not just at the very end of life, which is unfortunately sometimes when people remember to refer, but early on, early and often, that they can just be a fantastic resource in helping you and helping the patient navigate these situations. So I want to thank you both for a really fantastic discussion. I think you are more than prepared for fellowship, and I look forward to seeing what you guys do and learn over the next few years. Any other thoughts that we didn't talk about?
No, thank you so much for having us.
Yeah, and thanks for facilitating this. This is, like you said, extremely important. And I'm really glad that we had this chance to flesh all this out. I know Emily and I, like we saw in this, we experience these things quite often, but it's kind of just something that you learn and kind of get comfortable doing, and I think that we are, I would say, despite the fact that we're still in residency, it's almost, this gave me a chance to reflect and see how much of this we've already experienced at our program. And so I'm really thankful for that.
And also still how much I have to learn about it. It's complicated. It's not they're not simple discussions. They're quite heavy, and it's so much involves responding and reacting to the patient and the family that you have in front of you. It's not a cookie cutter conversation that you can have by any means.
Yes, exactly. You can think of good phrases, but every patient is different. Every family member is different. Every family meeting you have is going to be different from the last. So thank you guys so much again for being here. And I look forward to chatting with you again, hopefully soon.
Wonderful.
Thank you so much.
Thank you guys. Take care.
Bye.